Lakeland Currents is sponsored by Nisswa Tax Service. Nisswa Tax Service offers tax preparation for individuals and businesses. Across from City Hall in Nisswa and on the web at nisswatax.com.
Hello again, everyone, and welcome to Lakeland Currents. As we start the new year, there's always a challenge to putting together programs when we do something that's for the whole public. And I think we have a topic today that really will interest every single one of us. It's called palliative care. And palliative care, as you will see in a little introductory clip that we're going to show you, is a very important bridge to going from healthy to being not so healthy. So before I introduce my guest, I'm going to have us watch this little clip on palliative care, and then I'm going to come back and introduce our guest, Dr. Julie Benson.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic. Traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
That's a pretty darn good little clip and giving an overview of what it is we're going to be talking about today. My guest today is Dr. Julie Benson, who is a medical family practitioner at the Lakewood Health System at Staples. Welcome to our show.
Thank you.
The first question I would have is, what is your role as a doctor at Lakewood in palliative care? Are you doing something unique from most of the doctors, or is what you're doing what all the doctors are learning to do?
I function as the medical director for our palliative care and our hospice programs, and we'll talk a little bit about the difference between those in a second. As a family physician, there's not a huge difference in some of my training. I did get some extra training to be board certified in hospice and palliative care. Most of my family practice partners do from birth to grave family medicine, and so you do a lot of this, but there are some patients and families who need a little extra specialty type level of care, and that's what I try to provide with the team of people that I have working with us: physicians, nurses, social workers, chaplains, pharmacists, therapists, volunteers.
Now, we use the terms palliative care and hospice. Mm-hmm. Are they one and the same, or are they different?
They really are different. All of hospice is palliative care. So palliative care is really about a team of people coming around a patient and a family when there is a life-threatening, a very serious illness. And it can be related, it can be ongoing care for months or years. Hospice is a subset of palliative care, so it's a very specific definition, and it really is meant for the last perhaps months of someone's life. Sometimes it's days. It's also a very specific Medicare benefit, and so in this country we talk about hospice both as an insurance benefit as well as a philosophy of care. But hospice in general, most of those patients have chosen to forego further curative treatment, and they're really going to focus on symptoms, whereas in palliative care you might be getting concurrent treatment for your serious disease as well as the support that palliative care can offer you. So They're slightly different.
I bet when you started medical school, this wasn't a term you heard much of.
No,
Did you hear of it at all?
The term palliative was really had almost a negative connotation, which was that's what you do when you have nothing else to do, and that's not at all what it means anymore. No, there was not a lot of training in that. I had some. I was very lucky to go to Duluth Medical School, which is very family medicine oriented, and when it comes to family medicine, this is part of it. But the majority of physicians my age and in my era and older got very little training in this. It's now becoming a standard of care in some of the training, but not nearly to the level that it really needs to be.
How much of this is changing because of the laws that are changing in our country? Is that changing this whole focus on palliative care that didn't exist 10 years ago?
To some degree, you know, actually the specialty's been around for several decades. It just hasn't had very much, any financial support maybe through the government. It hasn't had a lot of popularity within some of the other physicians and things like that. And so it's been around for a while. Certainly some of the change we're seeing in healthcare is pushing this because this is really good organized case management care, and so this is really good care. And so I think we're going to see with the Accountable Care Act this type of care really being the focus. We're kind of trying to stray away from fee-for-service. You come in for one episodic part of your care and then come back for it. This is really going to be about trying to take care of somebody for their entire disease process and not just sort of periodically. And so I think you'll see this type of care being modeled in other areas, not just palliative care or not just end of life.
It's so much fun to see new babies and to see new life, and I'm sure that's probably an exciting part of a doctor's life, and to be able to take care of people when they're not critically ill. It must be taking some special kinds of people to work with end of life. I mean, I can't imagine that everyone is suited for that role. Is that a fair assessment?
I think that's probably true to some degree, although I think that deep down inside, most of us would be able to do that if we're just trained how to do some of those things. But I'll tell you, the team of people that I work with are angels, and they are truly, truly very special people. Not everyone is comfortable with talking about end of life or even being around there. I really look at my job as from the whole spectrum, from birth to death, as one and the same thing. And you know, I on a fairly regular basis get to be present at a birth, and then turn around and be present at a death, or at least help a family come to terms with some of those things. And it's the spectrum of life. It's beautiful, and in fact, if I didn't have one, it would be harder to do the other. I think you have to have a little bit of both. So I love it. I see it as very much the same thing. I frequently talk to families even about how the dying process is really a rebirth in another way, and so sometimes, you know, those things can help them as well.
Let's come back to that in a minute, but what is a team made of?
So our team, in general, a palliative care team is going to be interdisciplinary. For sure, it's not going to be just one person doing this. And in general, most interdisciplinary teams will have some sort of medical provider. So in our situation, it's myself as a physician, but they may have a nurse practitioner. In fact, many are run by advanced nurse practitioners. They do an amazing job. Physician assistants also have roles in that. There's frequently RNs, sometimes some LPNs. Almost always there's a pharmacist involved somewhere along the line, and I believe spirituality is a really, really big component of this. So most will need some sort of access to spiritual care, and as well as some mental health care. We usually have some volunteers involved in there, and then depending on where you're at and what your resources, you might have massage therapist, physical therapist, occupational therapist, those types of other supportive cares.
So if a patient comes in and you're in a situation where you're going to need this kind of care, does this team work with that patient kind of one-on-one, or do you do it as a team to start with? We
do both. Depending on the situation in which we're brought in or we're asked to be brought in, we try to assess what the patient's needs really are. And so if we're being brought in because there are some specific symptoms that are not being well managed and they're difficult to manage, that might bring in one part of our team for another. If we're being brought in to help families talk about goals of care, so maybe this is mom in her 80s, and she's got fairly significant dementia. She's been hospitalized over and over and over again, and maybe no one has actually said, how do you want to keep doing some of these things? Let's talk about what's most important to her. What would she want if she were able to tell us what was going on? And so that might bring in a different part of that team. We try not to overwhelm people. And we also try to preserve the relationship that patients have with their primary care provider. We feel very, very strongly that most patients have a strong relationship with that person, and so my role is not to interrupt that and come in and now be that physician for them. My role is to actually act as a backup to that primary care physician, to maybe be available if they're not available, to answer questions if they're not available, those kinds of, and our team kind of supports that relationship, so family, physician, and patient all together.
So are these teams put together after, I would guess, after a doctor has led the discussion that we're reaching a stage here?
You hope.
Critical,
Yeah.
but maybe
but
not
always. No,
not always.
Actually, many of our referrals actually will come. Sometimes they come from family members themselves. Sometimes they come from nurses. We might get a referral from one of the nurses in our infusion therapy center saying, this gentleman's really struggling with some things. He could use some extra help and some extra care. We'll get the referral, and then we'll try to kind of figure out what his needs are and then pull that team together. We meet on a regular basis. At least every 2 weeks, the whole team sits down and goes through every single patient on our service. And we make sure that we get up to date on things. We make sure that we're looking to see if there's any new problems. We try to predict if there's something that's coming up. So maybe someone has been struggling a little bit more with their nausea and vomiting after chemotherapy, and so as we look at, okay, their next round is coming up, maybe we need to tweak medications to try and prevent them from heading into a crisis or coming into the emergency room. But we meet as a team, and so there's a whole bunch of us sitting around a table, and then whenever necessary, maybe the nurse and the social worker will meet with the family and the patient, or maybe I'll be brought in to meet with the family and the patient. Maybe it's at home. Maybe it's in our hospital, maybe it's in the clinic even. Sometimes my staff spends time with our oncologist and the family so that they can have an extra set of medical ears to kind of interpret what's going on. And so we try to provide this service actually in a variety of venues. So we're in the care center, we're in the hospital, we're in the clinic. I do home visits, I'll do family visits wherever someone needs something.
So in your team, how many teams do you have at Lakewood? Do you have just one basic team?
I have a specific palliative care team, and then we also have a hospice team that deals just with hospice clients, and there's some overlap. Our chaplain is the same, our pharmacist is the same, I am the same, and our social workers. So we have a little bit of overlap.
So I'm certain all different situations are different, but there certainly are, I'm sure, times when family members have a hard time grasping onto what this really is, and maybe even deny that.
Yep.
Do you have people in your team that specialize in working just in those environments?
Yeah.
You do?
I mean, most of us have had some training in that and some experience, and actually we don't necessarily say, oh, this goes to this person. We'll often sort of say, who's got a good relationship with this family? What seem to be the barriers about this? We try to figure out if there's something else going on that we might be able to help them. And there might be reasons that someone is in denial or not. That's a hard term to use sometimes. And we try to figure out, what kinds of information do they need to hear to help them kind of come to some understanding about what's going on. So it isn't necessarily, we all have our certain skill set, and sometimes it might be the chaplain that is able to really get some of this drilled down, because maybe they're very worried that if they stop therapies, then does that go against their religious beliefs, and does that mean that they're not going to have maybe the same kind of afterlife that they might want to have? And so, and maybe it's anxiety, and so maybe it will be working with the social worker to do some relaxation techniques or something to help them kind of come to terms with what's going on. So it really varies.
Wow. You said that there's a certain beauty to the end of life, and I know in our email conversations you were talking about death cafes, and, and another term you had, and I'm sorry it slips my mind, but what are those? And I can imagine that family members, sometimes it's just a person or two. It's really a lonely world out there, isn't it, when you find out your spouse or your family member's dying. What are those kinds of events?
Well, a death cafe is actually...
it sounds morbid, but I know that's not the intent.
Well, actually, the philosophy behind that is really trying to have conversations. So much like this isn't necessarily specific to a specific patient or a family, but it's actually trying to have some social normalcy around these conversations and saying, hey, let's sit down and let's talk about these things. Let's talk about why is it so hard to talk about death. Death is normal. Death is going to happen. 100% of us are going to die. But we don't talk about it very much. Statistically,
we're not ready yet.
We're not ready yet, and that's fine.
We all want to go to 110.
We try to talk about that this isn't necessarily about dying, it's really about living, but there are some things you have to do while this process is happening. And so while we might hope for the best, you sometimes also need to prepare for the worst. And so trying to normalize this, trying to get people to talk a little bit about it, and we'll talk, I hope at some point, a little bit about advanced directives and bringing these topics up with your family and stuff like that. But Death Cafes is actually sort of meant to be, there are also some dinner parties around that, and just basically let's talk about this, let's try to take the stigma out of this, let's answer some questions about these things. So you'll see that's kind of a grassroots movement maybe to talk about some of these things maybe in some of the bigger cities, and sometimes they might have poetry involved with it, or they might have some other things, but that's a little bit different. That's really sort of a social movement to try and demystify death, because it's going to happen in some way.
And you said, talk a little bit about that. You said there is a certain beauty to it.
Mm-hmm, absolutely. I feel very strongly that not everybody's death will necessarily be viewed as beautiful, and I realize that it really depends on where you're coming from in your own experiences, your own background, and what you've seen. But we strive to try and identify what would make something a good death for you, or for a family member if that person's not able to talk. What do you visualize this? We tend to think that we're going to die quickly. 10% of us will die quickly, a sudden death, a heart attack, a stroke, a car accident. 90% of us will die over a period of months to years of a slower, more degenerative process. But we all talk about the other part, the 10%, and that's all what we hope for. So what would a good death look like? And some people like that term, some people don't. It doesn't matter to me a whole lot whether you like that term or not. But I think that death can be viewed as beautiful, and if we can help a family come to see that it's okay to let go, that someone is comfortable while they're dying, that their symptoms are relieved, and many times family members are ready, a patient is ready to die, but they might not, they might be afraid that their loved ones aren't ready for that, and so they might continue to do certain therapies because the other people around them aren't ready for some of those things. But death really can be quite beautiful. It can be very, very peaceful. When I think about a recent death, family members were all sitting around, holding hands, talking about the old memories. There was a nephew on the phone that was involved who couldn't be there but wanted to be there, as Uncle was dying. Those types of things can really be quite beautiful. And if afterwards the family comes out of that and goes, okay, we're okay, the studies will show that months later their bereavement, their stress levels are actually much better as well.
Because for the unprepared, these deaths are some of the most stressful events in a human life, aren't they? Absolutely. So your educational approach is preparing people for how to cope.
We hope so. When 50 years ago, when women were getting ready to have babies, there was very little prenatal education. You just came in and you did what you did, and you sort of hoped someone was going to be there to help you, and they were trained to do that. Enter prenatal education, and women became empowered by information, and I can choose this and I can choose that, and wouldn't that be great if I chose to have this type of maybe pain medication or different decisions that they can make about their own labor and delivery, and they were empowered by it. I really think that we need to have that same philosophy and empower all people to make decisions about what might happen at the end of life, whenever that might be. And we can talk about it now, and it might not be for 10, 20, 30 years. That's okay. You've at least had a chance to talk about some of those things.
I can imagine that as a doctor or as team members, you've seen tremendous growth through yourselves in dealing with this, with families and patients.
Yeah, I mean, it doesn't come easy necessary, and I was just working with some medical students yesterday, and we were actually talking about some of these things. We were doing some discussion about how to give someone bad news, and those aren't things that come naturally. Med students are taught, certain things. Here's the antibiotic you use for this. This is the surgery you need for this. But to try and help them develop skills to talk to people, it doesn't always come naturally, and you have to practice it. And you have to practice it a lot. And I hope I'm better now than I was 10 years ago, and I hope I will be a lot better.
Is that how long you've been doing this? About 10 years?
Yeah, right around that. Yeah.
We're down to, we've got about 5 or 6 minutes left, but I wanted to spend a little time on the document you gave me, Dying in America, which suggests, and I took the test at the end of this, I didn't do very well in the test.
Okay.
And I think that's really interesting you say that 10% of us are going to die a violent death or from some kind of a quick action.
Yeah, a quick death, yep.
Where 90% of us are going to spend a longer period of time. And as we know, sometimes that can be a very long period of time, very painful. But I have an extended family member right now who's in hospice and is not expected to live very long. And to some of the members of the family, I said, really, they just can't grab onto it. They just haven't been able to do that yet. So this kind of a program I could see would really be helpful to the family.
Yep, and that's really what hospice is, a specialized form of
palliative care. And they are
working
with hospice.
And they will work very, very hard to work with them. And depending on what their needs are and what they're willing to work with, not all family members are willing to work with them, but hospice is a very specialized form of that, and they're excellently trained to do those things.
So most of us really, I think, are built to think that we're going to live forever. So we don't really make plans for when this does happen, do we?
No.
And one of the things that this study did that you gave me, it made recommendations on how we should start preparing ourselves. And I think it's something that I'm going to start doing because I haven't done this either.
Okay.
What are some of the things that's being suggested here? It doesn't matter how old we are. It could be 25, it can be 100. But we need to start making some plans for when we leave, don't we?
You do, and it doesn't have to be real in-depth depending on where you are. For young, healthy people in general, we're not going to be able to predict what might be some of the decisions that they have to make. But I recommend that people even just think about who might be a decision maker. So in the event that I'm not able to make my decisions, who might be my surrogate decision maker, sometimes called the power of attorney for medical decision making, those types of things, and just say, this is who I want. I want my brother to make these decisions for me. Then you also need to have that conversation with that person so that they know in general what your feelings are. As we age or we have life-changing events that happen, a divorce, a marriage, children, you might have to tweak some of those recommendations or who you name as well. But whenever there's a diagnosis that suddenly changes your life too, you should re-look at some of those things. And then I usually tell people to look at them again every 5 to 10 years unless something else comes up in the meantime. But you should start, besides naming those things, what's your general philosophy? What makes life worth living?
Should this be in a written form?
Yeah, and you can Google, you can go online and just look at advanced directives, sometimes called living wills. You could Google that. And there's many of them. In the state of Minnesota, most of them are legal documents. You can have them notarized or you can have 2 witnesses sign off on them, and so they're essentially free. There are some documents that are a little bit kinder and gentler. There's a document called the 5 Wishes, which is really a beautiful document that walks you through making some of those decisions. So the hard stuff like...
Can that be Googled?
Yep, absolutely.
It's called the 5 Wishes?
The 5 Wishes, yep. And I think there's a fee for that one. At least there was in the past. I'm not sure if there is right now. But talking about some of those things, but then if you have a specific diagnosis, so let's say I'm diagnosed with end-stage kidney disease, and maybe I'm on dialysis, and that's an appropriate treatment for me. But let's say I determine at some point the quality of my life isn't where I want it to be. I might make some decisions about how I might outline for my family members how I want to be treated if I'm not able to make my decisions anymore. At what point would I not want to continue on dialysis or something along those lines? And so it can really vary by disease status. It might be a cancer we're talking about, might be congestive heart failure, might be advanced dementia. And dementia in particular is one that is near and dear to my heart because as we advance through our dementia, it's harder and harder to make those decisions. And so I think you have to have some of these conversations very early in the disease process. What do you value? Many times people will say, I don't ever want to be in a long-term care facility or something along those lines. But that might not always be possible. But if you've told your loved ones that, they might be able to make some arrangements or at least understand that mom doesn't want to be kept alive with tube feedings if she's going to be in a care center. So that might help make some decisions about letting go, too.
And it really is interesting. I remember one time I was at Abbott at the stroke center, and I couldn't believe the number of children who have had strokes. And I mean 3 and 4 and 5 and 6-year-old kids who are unable to move. So we're never too healthy or too old to start making plans like this, are we?
Yeah, I mean, I tell people it's almost like an insurance policy, you know, that this shouldn't be done in sequence to different things, but it should really be done in parallel. Get your homework done. It's like an insurance policy. You never want to have to use it. Get it done. Now it's there. If there's been a change in your life, relook at it. Make sure that you're up to date on those things. Reevaluate, and then kind of put it behind, because it's not, life is not about dying. Life is about living. And if you can have some support, we can actually live, hopefully, you know, a robust life and as comfortable as possible until whatever disease process happens.
Now, I'm sure you have some people who are in situations like this without insurance, and some that have insurance. Can you deal with the families who don't have insurance?
Yeah.
And how does that
we
handle?
try very hard. I mean, we try to access things through county services. That's actually one of the main things our social workers will do, is try to figure out what kind of resources they might be able to access that they haven't accessed. We look at philanthropic ways. We might be able to access something through maybe the Veterans Administration. So maybe they haven't been part of that for a while, but that could be some other payment source. But our belief, our philosophy, at least at Lakewood, is really caring for that person regardless of their ability to pay. So we'll figure it out somehow, some way about what that might look like for them.
Are there any other things that you'd like to emphasize on the recommendations from this study?
You know, the recommendations, there were two main ones, which is we really need to talk about this in medical school and training for nurses, for social workers. Social workers actually get a pretty good training in that, but physicians, and we need to be very specific about getting them good training. And then we need to be able to fund this. The government really needs to figure out a way to fund some of these extra things. They're very good at paying for the removal of your gallbladder, but for me to sit down and have an hour-and-a-half conversation with you and your family isn't easily reimbursed, or it's not reimbursed by other people besides a physician. So for nurses to come and sit down and talk, it's hard to get those things paid for. And so we need to figure out a way to fund these conversations well ahead of time, not just in time of crises. The majority of these conversations are in crises.
How would people get in touch with what you're doing? Do you have a website that people
We do.
can go
Yep.
to?
You can go onto lakewoodhealthsystem.com, and as you page through it, you'll find the palliative care department. There are resources around. You can actually Google getpalliativecare.org, and they will talk about palliative care organizations even in your area, depending on where you are at. The Minnesota Network of Hospice and Palliative Care is developing a more robust website to be able to search not just for hospice agencies, but also facilities that provide palliative care as well.
Well, that's fascinating work. It really is, and I commend you for taking that part of your medical career and working with families. That's pretty cool stuff. It really is.
It's very rewarding. It's a blessing, and really, most of us went into medicine to help people, and this is a big important part of it. Yep. Absolutely. It sounds weird to say it, but I enjoy it.
Well, thank you for being on the show.
Thank you.
Very good information.
Appreciate it.
You've been watching Lakeland Currents, where we're talking about what you're talking about. I'm Ray Gildow. So long until next time.